We will continue our endocrine session now with an overview of thyroid disease. And it's my great pleasure to introduce our next speaker, Dr. Matt Kim. Matt is Assistant Professor of Medicine at Harvard Medical School, Clinical Director at the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital. Thank you so much, Dr. Kim.
Thank you. I don't have any disclosures to report. And today we're going to cover the essential points of 5 topics in the domain of thyroidology: hypothyroidism, hyperthyroidism, non-thyroid illness, thyroiditis, and thyroid nodules. So to dive right in, this is a fairly busy but comprehensive flow chart that outlines everything we do when we're evaluating patients with suspected hypothyroidism. And you can see it begins with measurement of a TSH level. This is the most sensitive index of thyroid function, and it's what we rely on. And we use this to classify most different forms of thyroid dysfunction. We're usually suspecting hypothyroidism when we detect a high TSH level. And that indicates that we're detecting underlying primary hypothyroidism. We often go further and check a free T4 level to try to stratify this. Patients who have a high TSH level and a low free T4 level have what we classify as overt hypothyroidism, and they definitely need to be treated with thyroid hormone replacement. It's not uncommon to detect a high TSH level but a normal free T4 level. And that's what we classify as subclinical or mild hypothyroidism. And this is something that doesn't always need to be treated. There's actually quite a bit of controversy about the indications for treating this. Detection of a normal TSH level almost always confirms that a patient is euthyroid and that you're not dealing with any form of thyroid dysfunction. But sometimes when things are checked for screening purposes, or even when a patient presents with hypothyroid symptoms, we detect a low TSH level. And this can at first seem a little bit confusing. In this situation, we almost always check a free T4 level. And if it's normal, then we have to consider the possibility that there's another form of thyroid dysfunction, that the patient might actually be mildly or subclinically thyrotoxic or hyperthyroid, or there's the possibility that they may be euthyroid and that this is just a temporary aberration that will revert to normal. But if we detect a low TSH level and a low free T4 level, then we really need to consider what we classify as secondary hypothyroidism, which is hypothyroidism due to pituitary or hypothalamic dysfunction. And then that would lead to an evaluation of pituitary function that would also often involve pituitary imaging. The treatment of hypothyroidism is fairly straightforward. Levothyroxine is the agent of choice. It's available in a number of different brand preparations: Synthroid, Levoxyl, Unithroid, and Levothyroid. There's a gel cap preparation that doesn't use any forms of powders or fillers called Tyrosine. It's actually available in a dispensable gel formulation as well. It's available in a number of different doses ranging from 25 to 300 micrograms and administered and taken once daily. The starting dose in most healthy young adults can be calculated to be approximately 0.8 micrograms per pound of weight. We usually underdose a little bit, as it's usually safer to start low and go higher if necessary. For older patients in the range of 60 to 65, we often start lower, usually in a range of 25 to 50 micrograms daily, and then increase as needed. For patients with known or suspected cardiac ischemia, we often start at very low doses on the order of 12.5 to 25 micrograms daily, and only increase doses gradually as we know it's not provoking or exacerbating any cardiac ischemia. In hospitalized patients, this often needs to be converted to IV dosing, and when it's done, the usual recommendation is to reduce the daily dose by 25% with that conversion. And doses are adjusted by waiting until we think we've achieved a steady state. In most cases, that takes about 6 weeks after starting or adjusting a dose of levothyroxine. As I mentioned before, treatment of subclinical or mild hypothyroidism is fairly controversial, especially in elderly patients. There have been a number of studies that have tried to determine whether there's any benefit to treating elderly patients with thyroid hormone replacement in this setting. There's a very large trial from the UK that recently seemed to show there doesn't seem to be any benefit in terms of improvement in symptoms or cognitive function. That said, we usually do treat patients if the TSH levels are consistently greater than 10 to 15. When treating hypothyroidism in pregnancy, Doses often need to be increased during the early stages of pregnancy due to the increased amount of circulating estrogen that changes the kinetics of binding proteins. And there are different ways of doing this. Some people empirically increase doses. Some people check doses and adjust as needed. The overall goal is to try to maintain TSH levels between 0.5 and 2.5 during the first trimester of pregnancy, and then continuing out for the duration of pregnancy. We're often able to reduce doses after delivery, and that usually has to be monitored fairly carefully as well. When we're treating secondary hypothyroidism due to pituitary or hypothalamic dysfunction, we can't rely on TSH levels anymore. They're not informative and they're not reliable. We really start and adjust doses to try to maintain normal free T4 levels. Turning to hyperthyroidism, this is a slightly more complicated flow diagram. But once again, when we check a TSH level in a patient who presents with palpitations or weight loss or increased anxiety and it's normal, we can pretty much rule out thyroid dysfunction as an underlying cause of those symptoms. When we check a TSH level and it's low, then we usually want to check free T4 and or T3 levels to try to stratify the different forms of thyrotoxicosis. And if we have high free T4, T3 levels, we call this overt thyrotoxicosis. But once again, it's possible to have a suppressed TSH level with normal free T4 and T3 levels that we would classify as subclinical thyrotoxicosis. The distinction between these two categories, it's a little bit semantic, but you're much more likely to just monitor patients with mild or subclinical thyrotoxicosis, where you're almost always going to be considering treating patients with overt thyrotoxicosis. And then once we've determined that a patient's clearly thyrotoxic, what we usually do is look for manifestations of Graves' disease. This is largely a clinical diagnosis, and if we can find clear manifestations that point to what looks like underlying Graves' disease, often that's enough to establish it. So the main thing we check for is eye findings, things that look like they're suspicious for Graves' ophthalmopathy, or what we also call thyroid eye disease. When we see proptosis, when we see a lot of eyelid swelling, a lot of bogginess and swelling of the conjunctiva, and injection that can be very striking, but usually isn't very irritating. If that's present, that's often enough to establish a diagnosis of Graves' disease. If we're not certain or we can't see anything that looks like a clear manifestation of Graves' disease, then the next step at the present time is to check TSH receptor antibodies. This is a laboratory test that in the past was not thought to be very reliable, but has actually become much more reliable with the use of certain automated platforms that have better reporting systems. We really feel like finding elevated TSH receptor antibodies is enough to establish a diagnosis of Graves' disease. But if we find that a patient's thyrotoxic, they don't have clear manifestations of Graves' disease, and we don't detect elevated TSH receptor antibodies, that's when we'll turn to checking a thyroid uptake and scan. And what we're looking for when we order this study is two things. We're looking for a level of uptake, and then we're looking for a pattern of uptake when we detect high uptake. So high uptake above whatever reference range is listed is characteristic of hyperthyroidism. All of that tracer has been taken up by the thyroid and deposited in areas of increased activity. Low uptake indicates that there's very little uptake of tracer, usually because there's been inflammation of the thyroid that's impaired its function, or in some cases because patients have been exposed to iodine that's blocked normal uptake of iodine. And we look for the patterns when we do see a high uptake state. These are images obtained with a gamma camera. You can see with Graves' disease, we see very intense uptake distributed throughout the thyroid. The overall thyroid is enlarged. In some cases, we'll see a strip up in the middle that's the pyramidal lobe enhancing. In patients who present with a solitary, autonomously functioning toxic adenoma, we'll usually see tracer accumulating within that adenoma, and there's usually suppression of uptake throughout the remainder of the thyroid. Patients presenting with toxic multinodular goiters can have very heterogeneous patterns of uptake. You can see there's multiple nodules distributed throughout both lobes. Some of them are very hot, taking up large concentrations of tracer. You can see other ones that are what we characterize as warm, still taking up tracer to a lesser degree. And then you can see they're actually cold nodules distributed within here. It's important to get these images when we see someone presenting with multiple thyroid nodules, because we need to know if we need to evaluate any of these nodules to determine if they could be malignant in order to best determine the route to treatment. Management of hyperthyroidism involves treating to try to ameliorate symptoms and then treating to try to control overactivity. We often prescribe beta blockers. They can help to reduce palpitations and tremors. Frequently choose once daily dosed beta blockers, including atenolol at doses of 25 to 50 milligrams daily, or long-acting propranolol at doses of 60 to 80 milligrams daily. Anti-thyroid drugs are a mainstay of treatment. We'll talk a little bit more about those. In patients who want to consider definitive treatment, we often administer doses of radioactive iodine. And the main thing to think about when you're considering referring a patient for this is this can't be given when patients are pregnant or breastfeeding. And if it is given to women of reproductive age, there usually has to be a long enough interval after treatment before they consider pregnancy. There are times when we refer patients for thyroid surgery for management of hyperthyroidism. Usually this is when a patient is allergic to antithyroid drugs and they either can't be treated with radioactive iodine or they refuse to be treated with radioactive iodine. Another circumstance where we consider this is in patients with large toxic multinodular goiters where they have substernal extension of nodules that's causing significant compressive symptoms. We're often reluctant to give radioactive iodine because we don't want to cause irritation and expansion of thyroid tissue that could really increase compressive problems. In terms of antithyroid drugs, the agent of choice is methimazole in most cases. This can be administered once daily. If you look in drug references, it often recommends that it be given twice daily or even 3 times daily. But its half-life is long enough that we're almost always comfortable administering it as a once daily dose. We usually start at doses ranging from 5 to 40 milligrams daily, depending on the severity of the hyperthyroidism. And it can take up to 3 to 4 weeks to see a real change when you're starting or adjusting a dose of methimazole. So we usually wait that long before checking repeat thyroid hormone levels. Adverse effects associated with this drug can include pruritus and a rash. This is fairly common, usually becomes manifest within a few days of starting treatment. There are rarer but significant side effects, which include agranulocytosis, hepatotoxicity, and a form of vasculitis. We don't routinely check things like white blood cell counts and liver function tests before starting treatment with antithyroid drugs, but if there's any suspicion that a patient might be manifesting one of these, then we usually check fairly immediately and have to stop treatment if we suspect it. Propylthiouracil used to be the mainstay of treatment for hyperthyroidism. It's really fallen off due to concerns that were raised about hepatotoxicity in children and young women who were treated with very high doses and in some cases developed fulminant hepatic failure. But that said, there are still some situations in which we consider using this instead of methimazole. Probably the most important is in young women of reproductive age prior to conception and during the first trimester of pregnancy if hyperthyroidism happens to be diagnosed during pregnancy. The reason we consider propylthiouracil or PTU is because methimazole has been associated with certain types of birth defects. So patients will often be started on PTU prior to conception or in the first trimester, and then if they're well controlled, in a lot of cases they're able to stop it altogether, but if they need to continue on antithyroid drugs, then we may consider switching them to methimazole during the second trimester of pregnancy. We also use PTU in cases of thyroid storm because it has the additional benefit of acting to block peripheral conversion of T4 to T3. It can help to rapidly bring down what may be very high T3 levels. And we may also use it when there are patients who are allergic to methimazole, who've declined radioactive iodine treatment or surgery. That said, about 50% of the time, patients who are allergic to methimazole may be allergic to PTU as well. And now we're going to talk about non-thyroidal illness. This is a presentation that's also been known as the euthyroid 6 syndrome. And what this actually refers to are transient changes in hypothalamic and pituitary function, thyroid hormone secretion, and deiodinase activity that can occur in the setting of acute physiologic stress. And this isn't really a treatable condition, but it's a bit of a challenge because these combinations of changes can suggest underlying thyrotoxicosis and or hypothyroidism in often acutely or critically ill patients. And we really want to avoid treating patients unnecessarily if they don't have any real underlying thyroid dysfunction. You can see this is a kind of stylized but characteristic representation of a lot of the changes that can occur during acute illness. You can see TSH levels tend to decline early on in phases of acute illness, but then with recovery, they can actually rise to above the reference range. You can see similar declines in T4 and T3 levels, that can usually take a longer time to recover. And the main problem with checking thyroid hormone levels in patients with critical illness where you don't have a very strong reason to suspect underlying thyroid disease or dysfunction is that you can be fooled. If you were to check a profile of thyroid hormone levels at this point, you'd see a low TSH level and low T4 and T3 levels. You might suspect that this patient has secondary hypothyroidism, and they might get started on treatment with levothyroxine that's not indicated and could even exacerbate things like underlying arrhythmias. By the same token, if you wait until later in the course of an illness and you check a profile of thyroid hormone levels, you can see a high TSH level and low T4 and T3 levels. And this would be very characteristic of primary hypothyroidism, but it could also just be the normal amount of change that you see with recovery. So in this situation, a patient would be prematurely started on treatment with thyroid hormone replacement that they may not need. And this is why we're very cautious to recommend checking thyroid hormone levels in acutely ill or critically ill patients unless there's a very strong reason to believe they have underlying thyroid disease or dysfunction. To mention points about thyroiditis, just a few things to point out here. There are really two forms that we're mainly concerned about. There's actually a form of thyroiditis that occurs with amiodarone treatment, but that gets to be pretty specialized. In most general care situations, the conditions that you might encounter would be subacute thyroiditis and autoimmune thyroiditis. And these are two different forms of inflammation. This is a granulomatous form of inflammation, and this is a lymphocytic form of inflammation. And they present very differently. And the key things to remember are that subacute thyroiditis is symptomatic. Patients present with very focal and characteristic pain localized to points within their thyroid gland itself. If you were to measure inflammatory markers, you'd find that they were elevated. If you were to check a thyroid uptake and scan, you'd see that it was low. Both thyroid pain and inflammatory marker elevations are absent in the setting of autoimmune thyroiditis. And in most cases, this is a situation where when we suspect this, we'll watch and we'll wait to see if this resolves. But we may need to treat the actual thyroid pain itself in cases of subacute thyroiditis. And this can be managed with high doses of ibuprofen, naproxen, aspirin, celecoxib, or if NSAIDs and aspirin are not effective, then we often have to consider treatment with prednisone at doses of 20 to 40 milligrams daily. Tends to work very quickly and is very effective, but when you try to taper this down, thyroid pain often recurs, and then patients get in cycles of having to resume higher doses. We'll usually treat either of these conditions with beta blockers if patients are having very disruptive thyrotoxic symptoms. And then both of these conditions can progress through hypothyroid phases. They can be temporary or they can actually be permanent, but depending on whether patients are manifesting any symptoms during these hypothyroid phases on the way to recovery, we may treat them with low doses of levothyroxine just to act as a buffer during that time. And then just want to mention one point about a form of autoimmune thyroiditis that's come to the forefront with the increased use of checkpoint inhibitors. I'm sure you'd heard a lot about these in other lectures in this course, but they're actually associated with very high rates of thyroid dysfunction. And that has to do with the fact that the immunologic enhancement can trigger new onset autoimmune thyroiditis. And it's a very striking and severe form of thyroiditis. On the order of something I don't think we've really seen happen with such regularity before. These patients can present with very severe thyroid toxicosis that's followed by a very rapid progression to overt hypothyroidism. And it took a while for this to be recognized, but now ASCO recommends that patients treated with checkpoint inhibitors, specific ones, nivolumab and ipilimumab, have TSH and free T4 levels checked every 4 to 6 weeks after starting treatment and every 2 to 3 weeks after diagnosis. And the reason for this really has to do with the rate of progression that you can see. This is what we might see with changes in T4 levels with normal onset primary hypothyroidism. You can see, and you can start at even a supraphysiologic level and then kind of drop to slightly lower than normal levels, kind of waver in and out of the normal range before becoming overtly low. But you can see that this takes months to progress. For patients treated with checkpoint inhibitors, it's a much more compressed timescale. And within 4 to 6 weeks, there's severe inflammation of the thyroid, there's leakage and very high levels of T4, but they drop off just as quickly, and then these patients can become very profoundly hypothyroid. And this is often happening in the setting of treatment of a malignancy, where you have to be careful not to confuse thyrotoxic and hypothyroid symptoms with the effects of the malignancy itself or the effects of other treatment. So we're often checking profiles of thyroid hormone levels fairly frequently and not waiting to treat these patients, often starting to treat them as soon as we see these drop-offs in thyroid hormone levels. Okay, then the last topic we're going to discuss, a very common one, thyroid nodules, very frequently encountered mainly on imaging these days, but also still picked up on physical exam. And the basic strategy in evaluating thyroid nodules, once you've felt or identified one on imaging, is to check the TSH level and a thyroid ultrasound. And we rely on both of these studies to help us determine the extent to which things need to be evaluated. If patients present with a high TSH level, then it's likely that they have underlying primary hypothyroidism, and it's very likely that that's due to autoimmune thyroiditis. We often check antithyroid antibodies. It's not always absolutely necessary, but checking them and confirming underlying autoimmune thyroiditis can help in the interpretation of ultrasound findings. There can be changes on ultrasound that look like nodules that aren't true nodules, but that said, you can still see nodules in the setting of underlying autoimmune thyroiditis. When we detect a low TSH level and we know that one or more nodules are present, then the question we usually need to answer is whether the nodule or one or more nodules may be autonomously functioning, maybe hot or warm. And we really want to know that before we determine if patients need to undergo any kind of biopsy procedure. So in this situation, we usually check a thyroid scan. And when a patient has a solitary nodule, a thyroid scan can show uptake in the nodule itself, which we classify as a toxic adenoma. This doesn't need to be biopsied, but it may need to be treated in its own right. Or a scan can show that the nodule is cold and it's surrounded by increased uptake that's characteristic of Graves' disease. In this situation, the cold nodule would need to be evaluated with a fine needle aspiration biopsy. With multinodular goiters, it's a similar situation. We check a thyroid scan and we look for nodules that may be cold in the midst of warm or hot nodules, and then we typically plan to biopsy those cold nodules. And then the majority of patients won't be hyperthyroid or hypothyroid. They'll be euthyroid and they'll still have thyroid nodules. And then we need to determine which ones of these do we biopsy. And for a long time, it was really just based on a size criterion alone. People would say if a nodule is a centimeter or bigger, it needs to be biopsied. But with advances in ultrasound technology, it's really become possible to look at the ultrasound characteristics of nodules to determine which ones need to be sampled. And the American Thyroid Association has criteria that it set forth. We still biopsy nodules that are a centimeter or greater if they're hypoechoic or if they have suspicious features. If they don't, then we look at the echo texture, nodules that are isoechoic or hyperechoic, basically meaning the same attenuation or brighter than surrounding tissue will get biopsied if they're greater than 1.5 centimeters. Nodules that have a lot of small cystic spaces will usually only get biopsied if they're greater than 2 centimeters. And this is a diagram that shows a lot of these features, very helpful in referencing when you're reading ultrasound reports. But given that radiologists are the ones who are making a lot of these calls, the American College of Radiology has actually developed its own system of stratification. It's called Thyroid Imaging Reporting and Data Systems, or TIRADS. And it looks at a lot of these same features and assigns points for each of these features when they're found. Those points are added up, and then that breaks recommendations down into categories ranging from benign to highly suspicious. This is very helpful in that it actually gives recommendations about what to do at the time of the reading, whether something needs to be biopsied or whether it can be followed. And so if you haven't already, you're probably going to start seeing a lot of reports that include TIRAD stratification and specific recommendations about biopsying or following nodules. There's a system for classifying the cytopathology of nodules that's become very useful. And it breaks things down into essentially 5 major categories, ranging from benign to malignant, that are based on different estimates of the risk of malignancy. And these are helpful in determining management more than anything. We really do have kind of fixed categories of management based on these cytologic diagnoses. Benign nodules will often monitor with serial imaging. They may still enlarge over time. Nodules that are called atypical or suspicious for follicular neoplasm will often be biopsied with genetic profiling testing. And these are a number of different tests that are available. Some of them are mRNA expression tests. Some of them are mutation analyses. Basically, they're all very good at negative predictive values that tell us that something may be a low risk of being malignant, and that patients don't need to have it removed. In other categories where it's suspicious that a nodule may be malignant or it's overtly malignant, patients go to surgery, though it may be a hemithyroidectomy or total thyroidectomy determined based on the level of suspicion. So I'm going to have a couple of quick questions. So question one, a 33-year-old male is noted to have palpable enlargement of the right side of his thyroid. Ultrasound reveals a 3.1 centimeter nodule with smooth borders. Lab tests show a TSH of 0.1 and a T4 of 11.5. He reports a history of symptomatic palpitations and weight loss of 5 pounds over the course of 3 months, despite an increase in his appetite. He is not taking any medications and has not noted any problems with dysphagia or dysphonia. What should you do next? A, perform a fine needle aspiration biopsy of the right-sided nodule. B, administer a 15 millicurie dose of iodine-131. C, refer the patient to a thyroid surgeon. D, start methimazole at a dose of 5 milligrams daily. Or E, check a radioiodine scan and uptake. How do I know when it's enough? Okay, so most people pick the correct answer, E, check a radioiodine scan and uptake. So this is a patient presenting with a large nodule with evidence of thyrotoxicosis, and you really need to determine if that nodule is hot. If it's hot, it may need to be treated. It may need treatment with antithyroid drugs, radioiodine, or surgery, but it doesn't need to be biopsied. Hot solitary nodules without suspicious ultrasound features are never malignant.
Okay. Matt, I think we'll have to skip the second question because our time is up, but
Okay.
we'll get to, hopefully we can get to a lot of these issues during the Q&A. Thank you so much.